My name is Dr. Mark Huffman, and I'm a professor of medicine at Washington University in St. Louis. And along with Dr. DK Oji from the University of Abuja, we're delighted to speak with you today about operationalizing your implementation science research. These are my disclosures, some of which are relevant to what I'll be discussing today. Let's start with where we want to take you during this journey together, our take-home points. The implementation research logic model is a flexible tool that helps organize implementation research studies from the formative evaluation phase to implementation outcome assessment. We're going to walk through that implementation research logic model today so that you can incorporate it into your research. Next, the specification of implementation strategies and their mechanisms of effect are keys to estimating effect sizes and consideration of contextual adaptation for study project or programmatic success. Again, your project, your programmatic success. We will describe the hypertension treatment in Nigeria program, which is a large-scale, multi-level type 2 hybrid study that operationalizes the implementation research logic model, and specific examples of the model's use will be outlined so that you can use it too. By way of background, global hypertension is a major disease burden. These are data from the NCD risk collaborations that look at the treatment cascade for women on the overall left-hand panel. There's an estimated 1.4 billion adults around the world who have hypertension or high blood pressure. Many of the individuals with hypertension don't even know that they have it because in most instances, it is asymptomatic. So the first step in this cascade is to diagnose hypertension. The next step is to treat with pharmacotherapy or medications that effectively and safely lower blood pressure to reduce the risk of things like heart attacks and strokes. And then the last step is to control the high blood pressure or hypertension to target levels that we know help extend lives and reduce the burden of disease. Now, across the world, there is substantial geographic variation across different regions. You can see the variations in the treatment cascade on the right-hand panel. Think about where you live and work and how the communities in which you work with may face a high burden of high blood pressure and whether or not it's adequately diagnosed, treated, or controlled. Dr. Oji and I have co-developed the hypertension treatment in Nigeria program with many stakeholders in Nigeria. This is a type 2 hybrid implementation effectiveness study that's adapting the World Health Organization's HEARTS technical package to integrate hypertensive services into public primary care in Nigeria. Think about where you live and work. Are hypertensive services available in public primary care? The components of the HEARTS package include a standard treatment protocol so that there's a reduced amount of unexplained variability in treatment patterns. And this occurs on the national policy level. There's the Nigeria Hypertension Control Protocol. Think about your own context. Does a protocol exist? And if not, how can you contribute to the development of one? Next, patients with hypertension are registered and impaneled, meaning they're brought back into care so that they have ongoing engagement for their treatment and control of high blood pressure. This is operating on the health system level. Next, the World Health Organization HEARTS package in our program, we prioritized fixed dose combination therapy, multiple drugs that are formulated together to improve the effectiveness and tolerability to achieve high blood pressure treatment targets more quickly. This is again on the health system level. Our study also incorporates team-based care and supportive supervision. So these are health workers who need to understand about how to diagnose, treat, and control high blood pressure. And then every quarter, our team goes back to the health facility to provide ongoing supportive supervision. Lastly, for patients who continue to have uncontrolled high blood pressure despite receiving treatment at primary care facilities, home blood pressure monitoring and health coaching for a health worker visiting them in their home is a patient-level intervention that is found to be effective and safe. Throughout our study, We've also included a few additional strategies that are not explicitly outlined in the WHO Hearts technical package. We provided blood pressure lowering medications from December 2020 onward, and then transitioned to a drug revolving fund from June 2022 onward. This was intended to reduce the out-of-pocket costs associated with blood pressure lowering medications. Think about how those out-of-pocket expenditures, again, where you live and work, may influence the accessibility, both the availability and the affordability of the treatment that you and your patients might be seeking. So to conduct this study, we had 3 aims. The first is a formative aim, which you may be doing in your own research. And this is really to understand the context in which you're trying to implement the proposed pathways and strategies. So our formative aim included a system-level, large-scale hypertension control program that was adapted from the Kaiser Permanente, Northern California's model in public primary care facilities in the Federal Capital Territory of Abuja in Nigeria. We've completed this step. The WHO Hearts package is modeled after the Kaiser Permanente model, which showed an increase in hypertension control from approximately 44% to more than 90% over a decade of implementation. Therefore, it's considered the gold standard globally for a high-level system of care for hypertension. We also conducted implementation packages for the patient-level health coaching, including home blood pressure monitoring, led by community health extension workers in a sample of these facilities. So our second aim, because it's a hybrid study, is to evaluate the effectiveness of the system-level, large-scale hypertension control program, as well as the addition of the patient-level health coaching intervention. So we hypothesize that these interventions or implementation strategies will improve both system and patient-level hypertension treatment and control rates across 60 public primary care facilities. Lastly, our third aim, again, because it's a hybrid study, is to evaluate implementation of the multi-level intervention. For this, we use the RE-AIM framework that looks at the reach, effectiveness embedded in that second aim already, adoption, implementation, maintenance, and we also include factors such as acceptability and cost of the system-level hypertension program and the addition of patient-level health coaching, including home blood pressure monitoring. And we hypothesize that these interventions will reach the target population and will be adopted, implemented, maintained, acceptable, and affordable at the system and patient levels. Next, let's spend a little time with Dr. Oji to talk about the background that led to the development of this research proposal, the contextual factors that were considered, and the stakeholders who participated in the formative research.